Great. So hi, everybody. Mary Jane Burke here. First of all, thanks for being here. As a reminder, the session is being recorded and simultaneously translated in English and in Spanish. So my colleague Araceli Nunez is going to provide information for our Spanish speakers so they'll know how to access the translation. Thanks, Araceli.
Bienvenidos. Este webinario se transmite simultáneamente en español. Haga clic en el botón de interpretación del idioma que aparece en su pantalla si desea escuchar esto en español. Gracias a Marta Vitón, que es nuestra intérprete de esta tarde. Gracias.
Great. Thank you so much, Araceli. And so just to note, this is a session that we are going to be providing for our larger community. And this meeting will be happening each month. So we will continue to keep getting the word out to everyone. And in the event that we find ourselves in a situation that we think we need to have an additional meeting to provide important information, we will make sure that we'll always be flexible to do that. For many of you, you've been on many of these calls, and just want you to know that this represents over 250 different interactions that we've recorded over this period. And for that, we can be so very thankful to our public health partners, the entire public school team, all of our public school public health liaisons, and particularly to Dr. Santora and Dr. Willis. And so with that, Dr. Santora, you can go ahead and begin.
Thank you. Hi, everyone. This is a repeat of what I presented on Wednesday, some of it, but there are updates because things continue to change on a daily basis. So we'll go through pretty quickly, and have enough time for any questions and answers at the end of the session. You can jump ahead. This is a chart you all have become accustomed to. It's our epi curve, and you can see we are headed in the right direction down the mountain of our large Omicron surge. We're still having around 100 cases per day, which is higher than almost any point in the past of this pandemic, but we are headed in the right direction downwards, which is why you are seeing relaxing of recommendations at the state level and across the nation. But again, it's really important that when we're going down the mountain that we stay vigilant, because there are still risks of COVID infection right now, even though we're headed in the right direction. Like I said, we are still at very high transmission rates in our community, higher than they had ever been. So you still are at risk of getting exposed to COVID-19, even though we're on the way down. And so I think that's probably the most important point. We're headed in the right direction, but there's still a lot of COVID circulating in our community. Jump ahead. This is an updated slide than what I presented last time, because I wanted to be able to show the differences that booster makes in our community. We are a highly vaccinated and well-boosted community. We're not as boosted as much as we're fully vaccinated, but we can see from that top blue line is the high risk that our unvaccinated population carries because they are unvaccinated. There's a significantly higher risk of being infected with COVID-19 than among those who are fully vaccinated, which is the orange line, and those who are boosted. So yes, while we all know people who have had Omicron and they are vaccinated or boosted, there is significant protection that vaccination and booster offers, first in preventing infection itself, and second, preventing severe outcomes. We can imagine that the many people who weren't vaccinated or boosted would have had a much more protracted or severe case of Omicron if they did not have those early antibodies and protections that the vaccine offered. Jump ahead. This is another new slide that we were updated. Again, we're always trying to look at local data to understand what is happening in our community. And so this looks a little busy, but what you're seeing is 4 different periods of our pandemic. The first period is pre-Delta, pre-vaccine. The second is pre-Delta after vaccine was available. The third is during the Delta wave, Delta was introduced in April in our community, but really became the dominant variant from July through December until Omicron hit. And then the last phase of our pandemic is Omicron. And you can see in all of the waves and surges that we've experienced, how much protection vaccines have offered to us and the protection that being boosted has offered to us. With Delta, and you've seen this in the news, the being boosted did not offer the same amount of protection. There's some reports around natural immunity offering protection, which it does. Natural immunity, our bodies are amazing machines. And when we are infected and survive infection, we can mount a robust immune response. And that is what is mimicked by vaccines. But you'll see with Omicron, we have significant protections offered by boosters. What we'll be seeing as we move into the future is which populations boosters will be recommended for. I suspect when we had a much more contagious variant, there became a national call for people to get boosted to quell the raging Omicron in our community. As we move forward in the pandemic, I would expect to have more tailored recommendations from Centers for Disease Control about who has the most benefit from boosters, which will probably be those who are immunocompromised, medically frail, or have other vulnerabilities that increase their risk for hospitalizations or deaths. But this again just shows the phases of our pandemic and shows the protections that vaccine have and boosters have provided to our community. Jump ahead. That being said, and this is one of our key focuses in Marin County, we are a very vaccinated and boosted community, but there's tremendous disparities among both booster rates and primary vaccines among children based by race and ethnicity. So in public health, we're committed to addressing these disparities and achieving equitable distribution of vaccines. So we'll be working to shift from our mass vaccine operations, which many of you have benefited from, to shifting towards more targeted outreach and education towards census tracts where we know there's the highest rates of or lowest rates of vaccination and boosters in our communities of color and lower income communities, and working to have more convenient, accessible vaccines, for example, evening clinics, and really committed to our partnerships with our federally qualified health centers like Marin Community Clinics and our community response teams, which are community-based organizations across the county who provide supports to our vulnerable populations. Jump ahead. And this is just a look at the data. I know there's a lot of bars, but if you look to the far right, you'll see among the white population of Marin County, you'll see almost 80% of those who have eligible have received their boosters. And then if you go to the left, you'll see just under 50% of our Latinx community have received their booster shots, and just over 60% of our Black and African American community have received their booster shots. So we've always aimed since the launch of vaccinations to have no more than a 10% difference between the general population and groups by race and ethnicity. So you can see there's growing work to be done to achieve equitable boosters across our community. You can jump to the next slide. And this is just where we've reported a very successful campaign for providing primary vaccine series to Marin's children between 5 to 11, which is really critical for keeping our schools open and optimizing the number of in-person instruction days all of our kids have. But when you look by race and ethnicity, you can see again tremendous disparities, where 77% of our general population of 5 to 11-year-olds have received their first dose. Only 47% of our Latinx children 5 to 11 have received their first dose, and 24% of our Black and African American children have received their first dose. So again, this is where we in public health, one of our priorities has always been equitable distribution of vaccines, and we'll be shifting our focus. And again, really looking at the census tracts where we have the lowest rates of vaccine, and really just providing the outreach and education for parents to make informed choices around vaccinating their children. Jump ahead. And I just wanted to share this kind of good news story. There was so much talk about Omicron and the surge of Omicron that this story got lost in the news. At least I hadn't seen it until this week, where it's just an evaluation of our United States vaccine program. And a lot of us remember some of the dark days before vaccines when we were managing outbreaks in our nursing homes. And what we saw, and you might have recalled, is immediately within the month after vaccinating our nursing homes and populations, that we saw a precipitous drop in deaths that were caused by COVID just because of the success of the vaccine program locally. And this is just a look at our nation to see how many deaths, hospitalizations have been prevented by having vaccinations. And again, just so impressive to see that more than 1 million deaths have been prevented by vaccine. If we were on the same course we were before vaccines, we would have lost a lot more residents in Marin and in the Bay Area in the state. And each of those numbers reflect a life that is so valuable to others and why vaccines have played such a critical, important role. And even hospitalizations, if people have experienced individuals or family members who've had to be hospitalized, these can be protracted courses of hospitalizations where people have long-term sequelae after COVID-19 infection. They may have required intubation. And we're just, again, really fortunate that we one, prevented hospitalizations and families weren't impacted by hospitalizations. And two, we also were able to protect our healthcare systems from surge. So again, this just shows the success of this national program. You can jump ahead. So immunity is a fickle thing. It's one of our strongest defense mechanisms as humans is both natural immunity, and one of our man-made skills is developing vaccines to provide vaccine-acquired immunity, but with both natural immunity and vaccine-induced immunity, they both wane. And that's what we've experienced. And there's more research. And again, this is the challenge with this pandemic is we're always learning at the same time it's happening to us. There's a great study out of Wisconsin through the Epic Health Record System, which looked at 36 million patient weeks and found that unvaccinated persons were 44% more likely to get reinfected than vaccinated persons. And again, just really reinforces the role of boosters in our populations as we prepare for potentially future variants and waves of COVID in our future. Can you jump ahead? This is just an update on our schools. I met with, had a couple meetings this week with schools, and I just think it was really important to frame what schools are. As a parent, I always think of schools as the learning environment for my children. It's kind of where my focus is. And then our role in public health and working in partnership with the Office of Education, we were definitely focused on reopening schools for in-person instruction. But it's also really important to see that these are workplaces for adults as well. And our responsibility, and I think why we have been successful, is we recognized since the beginning that we needed to create safer environments for both students and staff, and recognizing that we need to have workplace protections for staff. So I know a lot of conversations are happening about focusing on the environments that allow children to thrive, and we'll talk more about masks and other things as we go forward in the presentation. But I think it's just really important to see that we also have adult staff who may have other comorbidities and have other family members in their homes that they may be worried about exposure to COVID-19, and see the benefits of continuing to mask, especially when there's high transmission rates in our community. So just seeing schools as both a learning environment for our students, as well as a workplace for our educators, who we are also thankful for. Jump ahead. So this is an updated slide, and it just reinforces what we have. Our hypothesis from the beginning is that schools are a stabilizing, structured, supervised environment. And when kids are in school, the community transmission of COVID-19 goes down, because when kids are out of school, we are gathering and engaging in the behaviors that COVID loves, especially during the winters when we're indoors and mixing households. So we saw the highest, this isn't surprising at all, we saw the highest case rate among our 12 to 18-year-olds. As you recall, we were early adopters of vaccines. So most of our 12 to 18-year-olds were vaccinated before school ended last year. And that's, so when Omicron hit, it was around 6 months after they completed their primary vaccine series, which left them vulnerable to infection. And also just the social behaviors of adolescents, again, are more conducive to COVID transmission. So that's something that has been, again, just showing this graph to me shows how critical schools are in slowing down COVID transmission, and just shows some of the dynamics. Whereas you look at the blue population, which is to our 5 to 11-year-olds, almost had half the rate of COVID transmission, because we see the disparities in our community, but 70% of 5 to 11-year-olds had received at least their first dose. So they are a more protected age group. And what also is finally very interesting, and I think will be interesting as parents make choices around vaccinating their 0 to 4-year-olds, is we consistently see the 0 to 4-year-olds are, even though there have been outbreaks in childcare settings, and those settings obviously with mixing children have, there's a higher risk for transmission. They're not the highest transmission rates, and consistently haven't been. So there might be some intrinsic factors to the 0 to 4-year-olds who might have recent natural immunity to other coronaviruses that are protective We know around half of these 0 to 4-year-olds are more cocooned because they're at home and they're not in childcare settings. And I also think it reflects the success of our childcare providers who have endeavored since March 13th to keep the doors of their childcare facilities open. And they've just done a tremendous job having the layered mitigation strategies to prevent transmission among their staff. And again, among an unvaccinated population of 0 to 4-year-olds who we know their behaviors are also very touchy and conducive to COVID transmission. So again, I think this slide also just is to celebrate the success of our child care providers and their efforts as well. Jump ahead. So this is just, again, our updated dashboard. It's different than you may have previously seen. We really are focusing on that left-hand side on our vaccination and booster rates, and we'll be updating that side. And we're no longer tracking school-based transmission. We really have demonstrated consistently over the past 2 years that schools are not conducive to transmission, and most transmission events do not happen in the school environment, but happen outside of the school environment, typically at home or higher risk extracurricular activities. And consistent with what we're seeing just countywide, we're seeing week upon week a smaller number of school-age students testing positive for COVID-19. Jump ahead. Anything you want to add to that, Mary Jane, before I keep going?
Nope. No, I think, no, nothing to add at this point. Thank you.
All right, so we've updated a 32-point plan. And I think that's really important just to frame where we were prior to January 4th. And there was a meeting with superintendents prior to school. When they were on holiday break, we convened together because when we left for school, Omicron was not surging at the same level it was surging prior to the return to school. Our primary goal was keeping, again, the doors open for full-time in-person instruction. You may have seen that there's other areas of the country that were not unable to open their doors. And again, I think it's because of the strong partnership we have had with school district leadership, school leadership and staff, and a commitment to this layered approach towards mitigation strategies, and also being ready to adapt and to have more restrictive guidance at the reopening of school on January 4th. With that, along with having access to home-based testing, again, allowed us to keep that focus of keeping schools open and students in school. We remain firmly committed to creating environments where students thrive and value how important sports and extracurricular activities were. But over the holiday break, we saw a lot of transmission activity among sports, which is why we were more restrictive. And the primary goal was really just slowing that transmission of a more contagious variant, which again, with how contagious it was, we weren't confident, 100% confident that all of our layered mitigation strategies would be effective at ensuring low rates of school-based transmission. So we always enter new variants with some unknowns and need to enter with humility, which is why we were more conservative. At this point, we've relaxed I think almost all of the guidance that we recommended more strict guidance at the start of the 2022 winter part of our school year. And we will continue to relax our guidance as permitted by state. Jump ahead. So the updates here, large gatherings are now allowed. We just saw a new update from the state. If you recall, they changed what is considered a mega event to 500 people after February 15th. So on February 16th, they returned to 1,000 persons for what are new requirements for mega events. So the vaccine verification and testing that's required is no longer for 500 persons events, which many of our schools actually could have 500 person events, but now it goes back to 1,000. Again, just reinforcing the importance of wearing the most protective mask you can that fits comfortably and you're going to wear consistently. So, and we know that's really important, especially with our younger students. Really encouraging everyone who has interactions with students to get boosted if they're eligible and be fully vaccinated. We're no longer suspending any games or teams due to outbreaks, but we're just following individual-based isolation and quarantine guidance and just recommending enhanced testing for those exposure events. Again, this is all in the process of relaxing, even though COVID rates still remain very high. Remember, it's still higher than it's ever been. Jump to the next slide. Indoor masking. This is probably the #1 email in my inbox is how does the state's change in its order affect indoor masking in schools? And the simple answer, it doesn't. So the state, if you go to their CDPH guidance, you'll see explicitly that schools and childcare facilities are excluded from the relaxation of the indoor masking order. And so indoor masking is still strongly recommended. It's just not required unless people are unvaccinated in indoor public spaces, with the exception of school and childcare facilities. We are under the governor's order, emergency order, through March 31st. We are not anticipating the state relaxing the indoor mask guidance before March 31st. Things can change, and we're always ready to adapt. If we see a real consistent drop off in COVID activity, that is possible that the state may provide an update sooner, but at this point, it is required for all students and staff to continue to wear masking while they are indoors. You can jump to the next slide. Outdoor masking. So we have aligned our outdoor masking guidance with the Centers for Disease Control and Prevention. So if you look at our 32-point plan, we recommend that staff and students should consider wearing masks in crowded outdoor settings and for activities with close contact with others who are not fully vaccinated. We are seeing variability between different schools on wearing masks or requiring masks being worn outdoors, and we respect that. Again, there's a lot of COVID transmission, and depending on the age of children, there's a lot of close contact. So public health defers to the school district and the schools themselves on their policy for outdoor masking. We will be updating our outdoor masking policy when, again, in alignment with CDC, when we return to moderate transmission. And that's where will be an express statement that masks are optional outdoors, and in general, people do not need to wear masks when outdoors. So, but we won't make that update until we hit moderate levels, which could happen. Probably it would be sometime in early March when we return to moderate levels. But that's the threshold for when we'll change our outdoor masking recommendations. Anything that you want to add on masking, Mary Jane?
Yeah. So can I I have many questions in the area, and let me just go through them. So first question, are we required as a school community to follow the governor's order?
Yes.
Okay.
So for indoor schools, regardless if it's private, independent, parochial, they must wear indoor masks. So it doesn't matter the status of the type of school, that everyone must wear masks indoors in California schools.
Is there any discrepancy between what an adult has to do and what a child has to do?
In a school setting, everyone needs to wear a mask, and everyone should wear the most protective mask that they're going to consistently wear. So
Okay.
No.
All right. Let's just go to the outdoor for just a minute. So our outdoor masking language had a strongly recommended, right?
Mm-hmm.
To wear. And as you said, some schools are having students wear masks outdoors, some are not. So would you say that it's actually optional to wear masks outdoors?
It depends on the policy of the school. We're seeing childcare and schools still have a policy for requiring outdoor masks, and some are setting a date when they're going to end their outdoor masking policy, and that's where public health respects the culture of the school, and the school knows best both the vaccination rates, the behaviors of the students, and is best positioned to make a determination around the outdoor masking policy. Mm-hmm. And again, the recommendation, if you read this, a lot of the playgrounds can be crowded outdoor settings where there's a lot of close contact with unvaccinated. So that's, according to the CDC, it would be recommended that people wear masks in those outdoor settings. Mm-hmm. Again, we strongly encourage mask breaks, and there's definitely plenty of outdoor activities that don't have close contact, and we strongly encourage kids having, especially younger kids, having mask breaks and setting up that supervised time where kids can have mask breaks and just have a break.
Mm-hmm. All right, so Lisa, when is it, there's some confusion about when will some of these decisions become local decisions versus orders from the governor? So I think you just said potentially that in perhaps when we get to the moderate level, this outdoor masking would be one of the things that you would be looking at to shift to straight on optional. Whether students, it's always easier, right? If people have some guideposts. Mm-hmm. We have 116 schools. We've tried to hang together in these areas, but just trying to determine. So in terms of inside, we got it out, and that for now, period. There's no ifs, ands, or buts. It looks like March 31st is the next time that the state will be taking a look at it. Let me ask you this. So outdoors though, bottom line is that locally, we may be looking, because it's not an order, correct?
Correct.
So different than the, whatever, we may be looking to change this slightly when we get to the moderate range.
Right.
Okay. Then let's just say it's March 31st and the governor changes and has language more like this for indoor, right? What will be the factors that you'll consider to determine whether or not, from the perspective of our local public health, we would be in a position to potentially say, it's totally optional. If you want to wear a mask indoors, fine. You don't need to. We're not recommending it or strongly recommending it. It is optional. Could you just describe what those conditions? We have a lot of people, I mean, on both ends of the spectrum, just for you to know. Some people that there's no way we want to not have masks given what we know about this mitigation strategy and the effects on our data, essentially. And then other people, we are so done with masks, worried about the implications for kids and staff and their interactions. Please, please don't continue this a moment longer than you feel is necessary.
Once we anticipate, because of our high vaccination rates and high booster rates in our community, that Marin County is poised in many ways better than other counties to relax as quickly as allowed by the state. So I would anticipate that if the state is relaxing, we probably have the local conditions and low transmission or moderate transmission that would support relaxing indoor masking as soon as recommended by the state. And even if it was my decision, let's say I had authority right now, and it was this, and the state said it's up to the counties. With such high transmission rates right now indoors, this would, if the state had let go early, it would probably be a place where Dr. Willis and I would consider having a local requirement for schools, because we have seen locally how protective masks have been in schools, and with the singular focus of keeping kids in school and preventing closures, it would be something that we would consider if the state relaxed when we still had high transmission rates. But I anticipate we'll be in a place where the state will relax when we're at substantial or moderate transmission rates, and as a highly vaccinated communities, we would align with the state and have indoor masking optional. And I think that's where we need to be compassionate and kind, and already start talking to our students and children about being compassionate and kind, because there may be children that want to continue wearing masks, or who families for very reasonable and strong reasons need to continue wearing masks because they might have medically frail or vulnerable household members. And I think that's where we need, again, to be compassionate, recognize there's different risk tolerance based on some real factors that families are navigating, either the conditions of their children or conditions of other family members, and just respecting individual choice as we move forward around mask wearing.
Okay, can we jump to vaccinations for a moment?
Sure.
So the question that continues to come up, and I'll just frame it for you. The governor said that once a vaccination is approved and we hit the next semester, then vaccinations will be mandated for that age group. Mm-hmm. So that would have been a situation, if we went to what he said in October, a situation we'd be dealing with now, given we're at the second semester, et cetera. What are you seeing in terms of, or predicting in terms of vaccinations and the requirement of vaccinations for students? And I'm just going to go to as they enter school in the fall.
So there's a Senate bill that's under consideration around that includes COVID-19 as one of the required vaccines for students. And that is a requirement for only allowing medical or religious exemptions rather than personal belief exemptions. And I don't know what the status of that bill is going to be or where that will land. And I think it really would be tea leaf reading. We the governor made a loud announcement that we're kind of first in nation around requirements for student vaccinations. And I think we're going to have to just follow the legislation in order to determine where we are. There's no update on the place that I go to look for updates. It's called Shots for Schools. There's been no update since the week after that national announcement was made. So I think this is where the devil's in the details, and we don't know. We are really, again, Marin County is very poised. You've seen by the vaccination rates, but we also have great disparities in our vaccination rates. And so we want to work to address that. And we also have seen that consistently, the most of the children and adolescents in Marin County, it remains a mild disease. So it'll be interesting. For example, the flu is not in the same list of vaccines that are required for attendance as a seasonal flu. So I really don't know how that Senate bill is going, the outcome of that Senate bill for a disease that's not, again, a standard bearer disease like measles, mumps, rubella, and the other vaccines that are currently required under SB 277. So
Okay.
I don't know is the answer to that.
Yeah, no, exactly. We had a conversation with Senator McGuire this morning, and he felt this, given his new position, that this will be one of the volatile issues that will move forward in this next period of time, but reminded us that even though there was a shift away from personal exemptions, when all vaccines became required, no more personal belief exemptions, that this will have to go through this legislative process so that we, get to the end of the story. So I think for people that are wondering, we actually don't yet know, but we do know that vaccinations do make a difference for people that are eligible, and we will continue to do everything we can to be sure that they are available for all in our community who want to have access. Lisa, they just were saying that maybe they're starting to recommend a fourth vaccination for older, vulnerable people.
Yeah, we haven't seen that yet. I think it'll be really interesting. So we're at this unknown state where we've had a large surge in Omicron. So we have high levels now of natural immunity as well as vaccine acquired immunity. And if you look into the past of our experience with COVID, we had a winter surge in 2021 that then we had a break, and then Delta introduced itself to our community really it first landed in April, but really we had our surge starting at end of June into July. We know human behaviors, that's when we start gathering and celebrating. And I would expect that surge, if there is another variant, and we have a couple slides that talk about the future waves, if there is another variant due to the high levels of protection, it would be later than that July that we experienced with Delta, because we have such a higher level of natural and acquired immunity than we had going into that Delta wave, that it could be a midsummer recommendation, again, for specific populations around boosters. And it probably would be age dependent and then medical condition dependent. So for example, a lot of the hospitalizations that we're seeing are persons who have obesity or who are have diabetes. Those are two key risk factors for poor outcomes. So it might be something that we look at boosters only for that specific vulnerable population. And then I think the timing of that will be interesting too, because you want to be boosted, just like the flu season, people try and pick when they should get their flu shot. You don't want your flu shot typically in June. You want your flu shot probably starting in October, knowing that flu season hits in January. So October is typically a good time. And this is where we just don't know when these next waves are coming. So what you saw nationally is that the CDC shifted its recommendation around boosters and who should get boosted when they saw boosters, not just as a tool for preventing severe illness and hospitalization in the most vulnerable population, but also as a tool for reducing the level of the Omicron surge nationwide. So there was a benefit for having a higher level of vaccine acquired immunity when we're managing the Omicron surge, which we're still in.
Next question is in the accountability area related to vaccinations. So when we're no longer required to wear February 16th masks indoors unless we are vaccinated, right? Then in that case, we are required to wear them indoors. Now I want to take that to the schools. And so there's a question in the chat about, so we're in a school now and they lift the indoor mask mandate, let's just say, right? Or they make it optional. How would the school know which children are vaccinated or not vaccinated, i.e. those who should be wearing a mask?
That's a really hard question. With adults, it's based on self-attestation. So when you go in on February 16th, when you go into a business, even though we're going to tell you you should wear a mask and you don't wear a mask because it's your choice now, you're testing by not wearing a mask that you're fully vaccinated. And so I think that will be one of the challenges that our school leadership have to manage. And I've already shown you data that should reflect to you that there's a lot of variation at each school level. What's the level of vaccination? And that might be where there's a recommendation of continue to mask unless a school has over, for example, an 85% vaccination rate. So again, I think there's a lot. It's a one thing to say we're going to relax. It's a second thing to say to make sure people are informed about the risk and benefits as we relax and looking at potentially at vaccination rates.
Mm-hmm. Lisa, it seems like you've been using the term endemic less. And so can you just address sort of where you think we are? Is there going to be another virus? Is there going to be another variant?
Yeah. So let's jump through the next. Yeah, I have the next slides. We'll jump through the next slides and that'll help. Oh, look at that. Did you know that was coming?
No.
So pandemic to endemic. And I think this is one of the, we are shifting. We're actively transitioning to endemic. We're not endemic yet. And I think all of us want to like wake up from the pandemic nightmare and go on our lives. And we're just not there yet. There's a very strong realistic probability that we're going to have another wave or another large wave of a COVID variant. We're cautiously optimistic that it'll be a contagious variant that's not very severe or virulent, but there really is no historical data that says that's going to be the case. What happened with Omicron is that in a very under-vaccinated community, the virus spread, developed mutations, and then emerged as Omicron. There's still tremendous amounts of unvaccinated geographies across the world where the next Omicron or the next variant is mutating and trying to acquire the factors that will allow it to live. And typically, viruses live longer when they're more contagious and less virulent, when they don't cause hospitalization and severe disease because people keep transmitting it. So that's an adaptive change for a virus, but we also saw Delta caused more severe disease and some more severe illness. And so that's an example where a newer variant was more severe, even though from an adaptation principle, that's not the smartest thing for a virus to do. But viruses are unpredictable, and we just need to be prepared that we don't know what the characteristics of future variants will be. We also have tremendous global mobility. Look how fast it took for Omicron to come from South Africa, and it might not even originate in South Africa. It might have been another country besides South Africa. But it was identified by South Africa. South Africa is a major travel hub. Went from South Africa to Europe, Europe to New York, New York to California. And so that's what we need to be prepared for, is that there's rapid moving variants due to high global mobility. We also are working with waning immunity. I remember where I was boosted. I was boosted, but in a couple of months, it'll be more than 5 months since I was boosted. And so when the new variant comes, my immunity will be waning. And there might not be an indication because I'm a healthy 40-something-year-old person, or maybe there will be an indication because I'm over 35. There might not be an indication for me to be boosted, which means that I'm not contributing to the community's defense against the new variant because my immunity is waning. We're also going to be seeing relaxation in infection prevention policies because we have tools we didn't have. We have vaccines, we have therapeutics. So we want to relax more and let people live without a mask and have large parties and go back to the ways we enjoyed, but then there's going to be higher risk of transmission. And then lastly, we're just a vulnerable community. We're an older community in Marin County. And so we always have to be ready to adapt if it is a more severe virus, that it could have a more detrimental effect on our community as a whole, because we're an older community with only 3 hospitals. Fortunately, we have high vaccination and booster rates that should be protective as we get through future waves. Jump to the next slide. So many of you have been tracking what is the urgency of normal. We value our respected colleagues who are advancing this conversation. I think it's really important for public health to have this conversation and to elevate the concerns of pandemic related policies. So I'm thankful for Dr. Noble and Gandhi and other UCSF colleagues for, again, elevating the conversation and serving as a countervailing view for how we move forward with public health policy. But there is a difference in approach between the urgency of normal and a public health approach. And with the public health approach, we're really looking at our collective responsibility as a community. How do we protect our most vulnerable populations? As you saw earlier in our presentation, how do we ensure health equity and address the disparities in our community? Seeing masks as an effective tool for protecting our schools. We also have differential perception of risk. For many children and adolescents, COVID is not as severe as a flu. For other children, it is. And we have higher hospitalization rates among children and adolescents statewide and nationwide for COVID than the flu. And then public health typically looks as a group rather than as the individual. That being said, we may, as I mentioned earlier, we might have very highly vaccinated, healthy schools where, when allowed by the state, can relax more quickly because of the protection that high vaccination rates have to offer, and the benefits of not having masks in those schools and returning to normal play and normal learning environments outweighs the risk. And I think we just need to be in dialogue regularly and have the transparency and have meetings like this as we're navigating those choices that are ahead of us, and just are fortunate for these opportunities to share what we're thinking. But again, we value our colleagues' contributions to advancing the dialogue and advancing us moving through to endemic, which we're not there yet. You can jump ahead to the next slide. And so why are we not endemic yet? And the main reason is because we don't know where we are. It's not like the seasonal flu where every October you get your flu shot. We know the flu season is really going to come in force in January. It's been predictable for years. That's what happened with the 1918 flu. And remember, that was a pandemic, and then now it's a seasonal flu. Or COVID can go the way of the 2002 SARS pandemic, where it ended after 2004. We stopped seeing SARS and diagnosing SARS. That being said, I don't know if the SARS pandemic ever really ended. We just didn't have the same level of diagnostic testing and surveillance that we had. So it could have had a few waves that we just weren't detecting. That was 20 years ago. The technology has advanced so much just in these past 20 years to do wastewater surveillance, to do sequencing on so many viral specimens and have rapid antigen tests. This was unheard of when SARS 2002 or MERS in the 2010s hit us. So we're just not at endemic because we don't know what to expect yet. And then endemic, just to remember, is not harmless. People die of the flu every year. They die of RSV every year, both young children and older adults. So when we accept every year whether we get our flu shot or not, are we going to gain the benefit of a flu shot? Or are we going to take the risk that we might get hospitalized based on our own individual risk? And just to remember, even when we call COVID, when and if we call COVID endemic, that people will still be hospitalized for COVID. People will still die of COVID, typically due to their individual factors that put them at higher risk for a poor outcome. Jump ahead. So we're going to look at this in 3 ways. We've been successful because of our layered strategies. We want to have a balanced approach, and we want to remain focused on the community. And these are just the last 3 slides. You can jump ahead. I'm really thankful. Since the beginning, we've partnered with school districts to implement layered approaches, and that has been super protective. We've used data-driven and evidence-based guidance, and as quickly as data and evidence emerged, we adapted our approach. Vaccination is going to remain a tool for the near future. We also have a lot of control with our personal behaviors. People saw when they got infected, it's usually when they're in gatherings. So when transmission rates are high, that's a time really not to engage in large gatherings. But again, people also need to enjoy their lives. So if people are going to make those individual risk decisions, we have testing like we have never had before. We have access to rapid antigen tests, and we'll be seeing on the future in the horizon just evolutions in treatment. It's not there yet. The therapeutics are pretty come with a lot of contraindications and adverse effects of the antivirals we have now. But in one day in the near future, we're going to have something like Tamiflu for COVID because of advances in technology. The next, you can go to the next slide, is really having a balanced approach. We always have seen health as not just the absence of COVID in our community, but the overall state of our well-being and health. And we know that there's harms that COVID policy has caused to our economy, to the individuals who have suffered unemployment, loss of income, just the stresses of parenting kids at home. There's been significant harms to our policies, and we really want to just be guided by the science and make sure we really weigh the risk and benefits of any of our recommendations. And again, shifting from these community level policies and mandates that you've seen to individual risk management, where you'll see public health weighing in is really only as it relates to our most vulnerable sectors. So for example, today we released our first responder vaccination and booster mandate. There was a gap that was healthcare workers and people who work in nursing homes were required to get vaccinated and boosted, but there was a carve out that did not completely protect our healthcare system and our most vulnerable populations. That Marin County went along with other Bay Area counties in implementing that order. So that's the space we see public health in, is addressing the needs of our most vulnerable populations and protecting our healthcare system and the staff who support those healthcare systems and public safety systems. But in the general population, it'll be shifting towards individual risk. And schools kind of land up in the middle, right? Where school is compulsory, it's critical, it's a critical part, it's the fabric of our community. And so I think that's where we have leaned into the space to keep schools open, and that will always be our focus, is keeping schools open and students being student-centered in our recommendations. Jump ahead. And this is the last slide. And this is us in it as a community. This is a contagious respiratory, airborne, person-to-person transmissible disease. And so we're dependent on each other for reducing the risk of COVID exposures. When we've been successful in reducing COVID rates, it's because we work together. We stay at home when we're sick, we wear our masks, we get vaccinated. We also have demonstrated that we need to adapt and learn from the science and respond quickly when there are changes. And again, as I've mentioned, that understanding there's a spectrum of risk. The risk to a 20-year-old is very different than a risk of exposure to a healthy 20-year-old is different than a risk of exposure to an older 9-year-old. And the risk of exposure to a 20-year-old undergoing chemotherapy treatment is very different than the risk to a 70-year-old who might be biking TAM every day. And so we just have to recognize that there's differential risks, and people are going to be making informed decisions based on their own risk assessment or risk tolerance. And again, just that focus in public health, of focusing on our most vulnerable populations. I think that's our last slide. There, my thank you slide. So today is Alice Walker's birthday. I did not know that. She wrote The Color Purple, and thank you is the best prayer that anyone can say. I say that one a lot, and I do say that one a lot. I'm just so deeply grateful, and I have deep humility and understanding for all the different sides of this, and I really do value the different perspectives and inputs that we receive from the community, and it does, our communications and our dialogue does make a difference in us understanding the full picture of the implications of public health policy. So thank you all.
Great, thanks, Lisa. Mike Grant, how about if you jump onto some of these questions that we haven't been able to get to? We have several minutes here.
Okay, thank you, Mary Jane. Yeah, so a lot of the questions were around masks that were really well addressed through the presentation and the Q&A in the middle. There's a couple sections. One is on vaccinations. When will we under 5 vaccinations be distributed?
So that's in the works as we speak. We always learn that, and we always forget this, that when we first start getting vaccines, we get a very small amount. So we just learned that our first shipment into Marin County will be for 800 vaccines, and we have around 10,000 children between the age of 0 and 4 years old. So our approach is working in partnership with our pediatricians and our family practitioners. One will be focusing on the most vulnerable. Sadly, there are children under the age of 4 who are immunocompromised and under chemotherapy and have other medical conditions. So will be prioritized for access to the first doses of our scarce resources. And second, we will be partnering with Marin Community Clinics and our other federally qualified health centers to ensure access to our most vulnerable populations. We're working now on planning with our healthcare partners, again, to ensure once we do have more access to the 0 to 4 vaccines, that parents who are seeking vaccines for the 0 to 4 year olds will have access in a timely way to those vaccines. But as you can see from the data itself that I shared earlier, this is not the same public health urgency or emergency in distributing these vaccines. It was an emergency in January 2021 to get vaccines to our older adults in nursing homes. People were dying every day, and that's a public health emergency. It was a public health urgency to vaccinate our school teachers and our children, our school-age children, to keep schools open because schools play such a critical role in the overall health of our community. It's important that, so it's not urgent, it's not an emergency, it's a public health importance that children and families with children of 0 to 4 have access to this vaccine. So I think you can even see how our role in public health is changing with vaccination as we're evolving in the pandemic. But more to follow once we have more information around how the public can access vaccines, both through their regular healthcare provider or through the county. We'll be sharing that with the school community and with our child care providers and our pediatricians.
Great, thank you very much. And then there's a little flurry of questions about end of school year activities and performances like prom, senior events. Will they require vaccinations? Will indoor basketball games require masks once the rules change? And then it's the schools and performances and musicals. So that's kind of a cluster of just events, big events.
I think we all want to see a very fun and open and convivial spring and summertime transition, including all the concerts and the proms. We are going to make our recommendations based on the current levels of transmission. I'm cautiously optimistic, like I said earlier, that we're not going to be in the middle of a Delta wave because of this higher natural immunity. But just remember, Delta hit us right during the spring fling prom season. That's when Delta hit us. And so I'm cautiously optimistic that the conditions and the transmission rates will be prevailing that support much more relaxed approach and hopefully a mask-free approach towards many of those events. That being said, I'm just hedging a bit because I want to have humility, one, to what is the next wave of a variant and just not overpromise and say, oh, public health, even if rates are high and people are getting hospitalized, public health is going to say, don't wear a mask. That's not going to happen. That being said, we also want to be deferential to schools and how schools are going to be interpreting potentially using testing as a tool or vaccine requirements. Like we said earlier, there's an unknown around what's these vaccine requirements from the state level. It might still be unknown in the spring or summer, or it might be known. So my vision is hopefully our students this year have a prom much more like my 1991 prom, where I didn't have to think about wearing a mask. That's I think our goal, but let's just stay grounded and humble and know that we might need to adapt. And we would only, again, recommend more stricter guidance if we think it's essential and to the benefit of protecting people from poor outcomes and protecting our healthcare system.
Lisa, I know that you're not recommending a huge surveillance testing when people come back from the February break like we did in January.
No.
Can you please describe why that's important?
Well, number one is that when we were coming out from the break, we were so fortunate. We had this access to tests that we never had before. It was the right test. It was a rapid antigen test. And it was at the top of a surge of COVID-19 Omicron activity. So we were able to then create another layer through using testing, and when the disease was highly, highly prevalent. Every day, the pre-test probability, you probably heard me say this before, like when there's a lot of prevalence of a disease, that's a great, rapid antigen test is a great test to use because a positive is most likely a positive. Every day, the number of cases are dropping, the value of those tests are going to go down. And so we want to also preserve tests for their best use, which is symptomatic testing. So we are not recommending, and it's also a different risk. The amount of gatherings and indoor gatherings and parties that were happening over the winter, even though this is a holiday break, it's a different pattern of behavior that we don't think is setting schools up for this same potential risk of a surge of students coming in with undetected Omicron activity when returning from ski week. It's a different prevalence of disease in our community and a different dynamic of the vacation itself. So we are not recommending surveillance testing, and we've never recommended surveillance testing except for that one return to school post-holiday break in the middle of an Omicron surge. So those would be the conditions that we would recommend something like this again. And again, there's a better use for the limited test kits that we have available is really for symptomatic testing, and then testing supports to exit isolation and quarantine so students can get back to school as quickly as possible.
So I know there's only a couple more minutes. There's a couple questions that have emerged for adult-only events at schools after February 15th, after the indoor mask mandate has been lifted. Could you have an adult event at school without masks indoors? It sounds to me like this is like an open house.
So we would say people, if we still have higher substantial transmission rates, people, regardless of where the event is, people should wear a mask indoors. If by the 16th, if suddenly it drops to moderate, which I don't think that's going to happen, then it would just be up to individual choice. When the K through 12 guidance itself says if the indoor masking is when students are present. So if students weren't present, it would be the should state rather than the must not state. But again, I think we've all just adapted that there's so much COVID circulating. This is even today is higher than it ever was at our Delta surge. We never had a date of more cases today than during the Delta surge. So again, just stay vigilant as we're coming down the mountain. That's again, when most injuries happen, is coming down that mountain. And so we are all relaxing, we're fatigued, we're weary, we're tired, we don't want to wear the mask anymore, we want to hang out with our friends, but also just be vigilant, and if you do engage in those activities, get tested, because there is a high prevalence of COVID in our community still.
Okay, Lisa, with that, thank you.
Wash your hands.
Yeah, wash our hands, don't forget, right. Lisa, thanks so much for your willingness to continue to communicate with us. I know we're in constant contact, but just note that to everybody, if something comes up, we see additional data in any direction that we feel is important to get the word out, we promise to do so. And thank you all for being with us today, and look forward to seeing you next month, if not sooner. Okay, bye everybody.
Thank you.